Good morning, everyone. Welcome to Integrative Medicine Grand Rounds. I'm Hélène Langevin. I'm the director of the Oser Center for Integrative Medicine. It's my pleasure to welcome today's presenters from the Department of Psychiatry at the Brigham. And the discussion is going to be led by Dr. Meghan Oser, who's the director of cognitive and behavioral therapy and behavioral medicine in the program in the Department of Psychiatry at the Brigham. And our other presenters are Dr. Abby Altman, Dr. Sonia Matwin, and Dr. Meghan Searl. So, Dr. Oser.
Okay, can everybody hear me okay right now? Okay. So, what I would like to do today, I'll cover very quickly, hopefully within 10 minutes or so. I'll introduce sort of the patient case, and Teresa's here actually with us today, and she'll be speaking at the end of the talk today to describe her experience. And the way I'm going to set up this patient case is I'm just going to describe her at sort of when she presented at the intake evaluation, so sort of how she showed up for treatment. And then after we go through the 3 treatment approaches, I'll then describe her treatment response and sort of the positive outcomes that occurred. Then, and I'll also describe a little bit about our clinic and our services, the broad overview of the contextual CBT model, and then our 3 co-presenters will be describing in more detail the acceptance-based CBT approaches. We'll go through 3 different types. So in terms of the patient, so when Teresa sought care here at Brigham Psychiatry Specialties, at the time she was a 59-year-old female. She was divorced with 2 children. She was referred by her PCP, and she was presenting with major depressive disorder in partial remission at that time. So she was referred in 2013, that's when she first saw me, for an individual evaluation. And she had seen her PCP and sort of re-engaged at the Brigham in 2012 in January, and it had been decades before she had engaged. There was a huge gap in care in terms of physical, mental health care, behavioral health care. Prior to that. So her PCP actually started her on Paxil at that time. So she had about a year of being on Paxil, 20 milligrams, and I think that's what also contributed to part of the partial remission when she was seeking care with me. To give you a little more background, so at the time of referral, part of her, a big contributing, I think, factor for the depression was her unemployment for the previous 4 years. So she had been out of work for 4 years prior to seeing me. Her job was very much mattered to her, was very meaningful for her, and she was laid off quite unexpectedly. She describes that when this happened, when this the layoff occurred, that it sort of shut her down. She states she didn't get out of bed for 1 year and stopped attending church and pretty much just kind of shut down her life at that point. She was diagnosed also, another I think important piece of why she was referred to me is she was diagnosed with Hep C about 6 years prior. And at that time, she said that she didn't want to initiate antiviral therapy. She had not sought care at hepatology. She really couldn't even say the words, "I have hepatitis C" to me in session. So that's how avoidant I think she was at that point of even acknowledging that she had this condition. And I think part of what this was about was her, the contraction of Hep C was related to a blood transfusion from a ruptured appendix at age 24, so it had been such a long time since this had occurred, and I think it was quite shocking that she was diagnosed with this 6 years prior. In terms of her overall history, so she does have a history of trauma. She has a history of sleep difficulties as well, which the Paxil somewhat helped with at the time. She had no history of suicidality, no history of violence, no psychiatric history or treatment whatsoever. She had never sought care for outpatient treatment. There was never any inpatient hospitalizations. And she also described at the time that she had been referred to behavioral health or psychiatry previously, but she had been very resistant to talking to any therapist, just very avoidant. That would be too emotionally overwhelming at the time. So lucky me, I get to treat her, and it's been a great few years in terms of the treatment. I will skip over a little bit of her history just for the sake of time. At intake, just so you do know that she did meet criteria for PTSD. I did a PTSD evaluation. Her PHQ-9 was like on the mild to moderate side, so it was a PHQ-9 at intake, and and she did meet criteria for generalized anxiety disorder as well. So, with that. So when she was referred to our program from a PCP. To give you a little bit of background about our program, we are embedded within outpatient psychiatry. We're the cognitive behavioral therapy program. There's 5 clinicians. We're at 3 different sites. We provide clinical service. We do a host of training and research as well. And for the sake of time, I will move on. So in terms of the broad overview of contextual cognitive behavioral therapies, this broad model is really couched in behavioral learning theory. And it's sort of a broad class of cognitive behavioral therapies that explicitly incorporate methods to promote acceptance of internal experiences. And I took this quote directly from a fairly recent article that I like the way that it breaks this down, that this model uses methods designed to reduce the automatic behavioral regulatory power of thoughts, feelings, memories, and bodily sensations, but without necessarily first changing the form or frequency or content of those experiences. So all of these that we'll be talking about today are designed to produce greater psychological flexibility. So there's 5 features that are worth highlighting of contextual CBTs. First, they target the context and function of the psychological event. So these are things like thoughts, memories, emotions, bodily sensations, unwanted emotions and thoughts, rather than the validity, the intensity, the frequency of these events. We really aim to promote broad and flexible repertoires rather than elimination of symptoms or an eliminative approach to syndromes. We're not quite as focused on diagnostic criteria and how much symptoms change. It's much more about, can you live a meaningful life, and are you enhancing and improving your functioning despite maybe having some of these symptoms or struggling from time to time. The other, I think, key feature is that it's applied to the clinician, not just the patient. So we, as clinicians, need to embody these models and these sort of these features. And it builds on other elements of behavioral cognitive therapies. I already described that. And these models also address more complex issues characteristic of other psychotherapy traditions. So more existential domains and themes like intimacy and meaning and values, rather than just sort of symptom-based. And I borrow this slide from Liz Romer as a presentation that she gave a while ago. I like this because I think it does encompass sort of the overarching goals of all of these acceptance-based CBTs that we'll be describing today. One is to increase acceptance or willingness to have these internal experiences rather than fight with them, to cultivate a compassionate awareness and sort of decentered stance towards your unwanted internal experiences, and then mindful engagement in values or personally meaningful chosen behaviors. And so what I wanted to do here was, in order to tie the 3 approaches together, our common thread is going to be looking at how they each address and aim to enhance openness, awareness, and activation or activity that's meaningful. And you can see here how we describe those. So awareness is this flexible and mindful attention to the present moment, sort of in an affectionate manner. Perspective taking. Openness is acceptance, diffusion, or cognitive distancing, emotion regulation, and metacognition. And then active really means meaningful action. So what the patient chooses in terms of meaningful values and actions and commitment to change. So I want to briefly go over the broad evidence base for these 3 approaches, just so you have some background going into this about where we're at in the literature right now with them. So with ACT, acceptance and commitment therapy, we say ACT, there's modest empirical support for depression and anxiety, strong empirical support for chronic pain, And it's listed on SAMHSA's National Registry of Evidence-Based Programs and Practices. To give you a quick rundown of how I'm categorizing strong empirical support versus modest, we're just using the Chambliss criteria, where they need to have at least 2 RCTs that show efficacy, and 1 has to be from an independent lab or not the treatment developer in order to be strong empirical support. Modest could have 2 RCTs, but they're both from the same lab, or they're from where the treatment developer originated, or a non-RCT, but also effective outcomes. Behavioral activation has strong empirical support for depression. It's listed in the National Institutes of Health and Clinical Excellence, the NICE guidelines in 2009, as well as the WHO organization in 2012 recommends behavioral activation for mild to moderate depression, and then in conjunction with antidepressants for moderate to severe depression. And then mindfulness-based cognitive therapy, as many of you might know, that also the NICE guidelines, the NICE CE guidelines of 2009 recommend this for current remitted patients with 3 or more depressive episodes. And just a little more background, there's 6 RCTs here. I think this data came from 2012, so it could be updated by now, showed that about a 44% reduction in depressive relapse risk compared to usual care for patients who had 3 or more episodes of depression and are currently remitted, so they're stable. Okay, and I will turn it over to Dr. Searl, who will now bring us into a more specific analysis and description of acceptance and commitment therapy.
Good morning. So my name is Meghan Searl, and my primary work home is the Division of Cognitive and Behavioral Neurology, which is now called the Center for Mind-Brain Medicine. So I'm a little bit different from these guys, but like my colleagues in behavioral neurology, we have connections to both psychiatry and neurology. So I want to give an overview of ACT. So like these other treatments, ACT is a therapy that fosters psychological flexibility, and it is transdiagnostic, which means that it wasn't developed for one specific diagnosis. It actually can be applied to many different diagnoses and life situations. And when we talk about psychological flexibility, we're really talking about the ability to be aware, present to one's experience, to be open, so to be willing and accepting of one's experience, and to be active, so to be engaged in the world in a way that matters, that is in accord with one's personal values. So a basic assumption of ACT is that most human beings, if not all human beings, suffer, not just people with living with illness or who have clinical diagnoses, but all people. And ACT posits that it is the nature of being human to get caught in patterns of thought, specifically language-based thought concepts that make it more difficult to live in the world according to one's personal values. And one of the primary reasons that we as human beings don't live according to our personal values is because we tend to avoid experiences that trigger unwanted thoughts, feelings, etc., even when having those experiences bring us closer to what we most value. And so, and this tendency, this experiential avoidance, as it's called, has been shown to be associated with higher levels of depression, anxiety, lower quality of life, some other negative outcomes. So ACT, through a set of core processes, helps people to live according to their deepest values because they've learned how to be present to the full range of internal experiences that come along with taking those actions. And as Meghan mentioned, that it's not surprising that given that ACT fosters a wide range of internal experiences, including unwanted ones, it's not surprising that there isn't a goal of symptom reduction or elimination, although it often happens. It's just a byproduct of the process and not a goal. So Meghan talked a little bit about the support, the empirical support, so I'll skip that. So ACT is not it's not a manualized treatment. It's not a specific codified set of techniques. It's a general strategy that's designed to be flexibly applied and can be done so in a number of ways. So it can actually look very different depending on what the context is and what the need is. ACT can be used individually. It can be used in couples therapy, in workplace trainings, in groups. It's very, very flexible. But at its core, it uses metaphor, paradox, and experiential exercises along with 6 processes, core processes. 3 of them are what we are going to be talking about today. So openness or acceptance, awareness, so being in the present moment, contacting the present moment, and action. And then there are 3 others that I'll talk about now. How am I doing for time here? Does anyone? Yeah. Okay, great. So acceptance is about meeting one's own internal experience without trying to change it, allowing it to be there, making space for it, being willing to have it there, not trying to get rid of any part of the experience. Cognitive diffusion is a little bit different. That has to do with noticing thoughts rather than being caught up in them, watching them, and there are some interesting experiential exercises that help to foster cognitive diffusion. They can be singing your thoughts out loud, for example. So having a thought, I'm worthless, singing that to the tune of Happy Birthday, for example. Saying it in a funny voice, saying words that are powerful over and over and over and over until they seem to lose their meaning. So those are some of these experiential exercises can be very irreverent and actually fun, surprisingly fun. So being present, being in touch with one's internal experience in a non-judgmental, warm, curious way. There's another process called self as context, which is a little bit sometimes harder to get to sort of grasp, but it's the idea that there is always a part of oneself that is aware of one's internal experience, and that is a constant that's separate from the thinking self. And then values and committed action, and that's really the piece about being engaged in the world, being clear about what one's deepest values are, and then being committed to acting in that way, to living in a way that is in accord with those values. So some other examples of metaphors and experiential exercises that are used in ACT are I'll first talk about openness. So openness is the willingness to feel unpleasant emotions in order to do something of value. So one metaphor that's often used is something called passengers on a bus. And the idea here is that that you imagine that you are the driver of the bus, and which is your life, your mind, and you are the bus heading in the direction of your values, but you can't really control who gets on the bus. And so pleasant people might get on the bus, people you don't really have any thoughts about one way or another might get on the bus, and then really unpleasant people might get on the bus. And how do you relate to those more unpleasant people who get on the bus? Do you try to get them to get off the bus? Do you argue with them? Do you ignore them? And the point of doing this is to help people think about how can we move in the direction that is in line with our values, even though sometimes people come on the bus who might be unpleasant, might be difficult, might tell us you can't get there, you aren't good enough, etc. So in terms of awareness, there are a whole range of different mindfulness exercises that help people to get in touch with their present experience, whether that is sensory or being aware of thoughts, making room for whatever the full range of experience is. And in terms of action, there are a number of different ways of helping people to clarify their values. Some of these are exercises that go through different domains of life and help people think through systematically what their values are. Others are more experiential, like imagining being at your own funeral and thinking about, looking back at your life, what would have been most important to you, and going back to recognizing that you're still alive, how can you actually live according to those values with that new perspective? So what we offer here at Brigham and Women's is a group format in addition to individual treatment, but the groups are typically 10 to 12 weeks, and they most often are for people who are living with chronic medical illness. Okay, so now I'd like to have Dr. Altman come up. Thank you very much.
Good morning, everyone. What I'd like to talk about today is behavioral activation. So I'll first start a bit with the theory and the model. When we think about behavioral activation, we are looking at that B in CBT, in the cognitive behavioral therapy, focusing on what we do, how we act, and more specifically, when we think about depression, what we're targeting is this lack of positive reinforcement, or really just any positive engagement in your life. This really sort of detachment from anything, or a real meaning in one's life due to the depression. And there's this pattern that depression is maintained or it's sustained by this lack of positive reinforcement. And within depression, we have that lack of positive reinforcement, but there are also these ongoing patterns of avoidance. So for instance, you may hear individuals with depression talk about how they were feeling really bad, and so to have themselves feel better, the only thing they could think of doing is to go to bed, because maybe if they take a nap or disengage in the world, they'll feel better. So we talk about that as negative reinforcement, this idea that if you remove something, so let me remove my sadness, maybe the hope is that I'd feel better. But what we see individuals experiencing here is that actually it has them feel a lot worse. So this idea that if we take something away, the sadness, the hope that we'll feel better, but it actually increases those depressive symptoms. So we introduce individuals to these patterns of what's happening here when we disengage in our life. And a lot of the time this is caused by the depression. It's not something they can do, but we want to bring awareness to this. And that's a big part of this theory of behavioral activation. So what we also see within the theory of what we at least are exploring here, this idea that a lot of this is also happening without awareness to it, right? So it's sort of this automatic pilot where you're living your life doing these things, like maybe going back to bed or avoiding positive experiences, and you're not really aware that this is happening. Sort of, you feel like you're a puppet, right? That you're kind of controlled, the strings are sort of being pulled, and you want to change, but you can't, at least you feel that way, but you're really not even aware of what you're doing. And so we're really wanting to bring awareness to these choices, and that these choices maybe aren't the ones that they would be doing if they felt better, or kind of they would dream their lives to be different. So we're working from this, what we say, outside-in perspective. A lot of folks say when they come into treatment, if I felt better, when I felt better, I'd be doing something different. But what happens? They don't start feeling better, and so no change happens. So ultimately, utilizing this treatment to bring awareness and being open to this experience of exploring something that you're really avoiding and not wanting to look at for obvious reasons, because probably you fear that it's going to make you feel worse. And we introduce the individuals to this idea that maybe you won't feel worse. So in terms of what the approach looks like, I'll be speaking about how it looks in this group context. You could also do this individually as well. The group we have in our clinic that I've been running now for a couple years, we've had about 8 cycles so far in my time here. It's a 12-session protocol. The first 5-6 sessions are really devoted to exploring the theory, getting folks really in the know about what we're doing to sort of track and be aware. One of the key components is daily monitoring, again, to bring awareness. A lot of times, as I said earlier, we just don't know. We don't know how often we're engaging in those depressed behaviors that have us feel worse. So we're monitoring our time, monitoring what we're doing every hour, and not just that, but also how enjoyable activities are and how important they are. We find that, a lot of the time we're engaging in things that actually don't bring us any enjoyment and really we don't care about as much. I mean, that might vary, but probably not both. We're also contracting for social support. Again, at least what we know in the literature supports, the more you have accountability, the more likely you are to do something. We contract for that with our clients. Also, that idea of the group. The group is sort of, I wouldn't say like a contract, but you're speaking and you're getting sort of that buy-in that the group is holding you in terms of offering you support. And then we have this activity selection and planning. So when we say activity selection, this is very much tied to this idea of value, looking into sort of this openness and awareness of what you care about. Some folks say, I don't even know what I care about, and that's a big part of the group too, to just sort of be open to exploring maybe what you don't know. And maybe you'll find something out. So it's not just saying, go ride a bike or do something because you should, but really this meaningful exploration of what you value. And then we actually set it on that calendar. We use those forms to bring awareness to choice of what you're doing, accountability to it. If you schedule something, it doesn't happen, rescheduling it. And that's a big part of the treatment, to just always sort of have it on your radar with that group support. And also this idea of reward. Remember, there's no really positive reinforcement or reward. So in the group, we offer opportunity and suggestions once the activity gets completed, and we say it will, to reward oneself. So we say, bring out all the bells and whistles, circle it on your forms, do a little dance. In the group, we definitely give that positive reinforcement, which is missing. Maybe it'll be a little external at first, but soon turns very internal. Unique to this protocol, I mentioned it's 12 sessions. The first 5 or so really focused on the theory, and towards session 5, 6, we start including these in-session activations, which is completely unique to our protocol, hasn't been done yet. Where we have presenters, experts in the community come in and activate with the group. Might not be really what you value, but let's just engage anyway. And we've had Tai Chi by Dr. Peter Wayne. He's come and really been one of our star presenters. Poetry, and we just engage our clients and take that chance. In terms of the awareness, openness, active piece, I spoke a bit already about the awareness piece. We want to break those patterns of automatic pilot. In some cases, we'll just bring that awareness to the choice of what you're scheduling. You may still choose a depressed behavior, but again, you're choosing to. And that's your choice, and you're choosing maybe away from your values, but at least you know that you're doing that. The openness, turning to what may be uncomfortable, including what we start with, that if you start doing daily monitoring, you might notice that all you're doing is depressed behaviors, you may feel worse, and we're going to be open to that. Opening to, as we've talked about already, this examination of what we're avoiding. Also this idea of being open to the process versus immediate outcome. What we find with folks is these goals that they set can be pretty lofty. I want to go to finish my college degree or get a job by tomorrow. And we're taking a chance of really breaking things down into components so you can get positive reinforcement sooner rather than later. We find, if you're going to have this goal that's really I wouldn't say far-fetched. I mean, if you could dream it, we'll try to break it down, but having there be opportunities that you can get success sooner rather than later. And also, I meant to actually add this to the awareness piece. The group has been really creative to think of ways themselves to bring awareness. One individual came up with this snap technique that anytime they make a decision, even if it's to go to the bathroom, to get out of bed, they snap. Again, breaking these patterns of automatic pilot. Again, the behavior may be something just created. I'm going to brush my hair, but I'm going to snap. Okay, and that's been actually really useful. We've borrowed that. Should write about that, really. Lastly, active. So again, relating to these values, that we're engaging in our personally chosen values, what you choose versus what someone says or what you think you should do, and having this openness to exploring that. Value-based action versus mood-dependent action. So you are going to feel depressed, but can we do it anyway? And in the group, we always just say, what could be the harm in trying? And if you're unsure in the group, we might just, if someone's saying exercise, let's get up and do a jumping jack and sit back down. Often it's the initiating, the first step, that's the hardest. And this also piece of choosing to commit, and also allowing yourself to be flexible, that part of rescheduling and the flexibility within that it might not be on the exact day that you chose, the exact hour, but can you reschedule it? Folks sometimes struggle with that, but always sort of, as I said earlier, having it be on your radar versus it being this automatic pilot that can just take over. All right, that's my speech, and I'd like right now to introduce Dr. Sonia Matwin.
All right, I'm going to be talking about mindfulness-based cognitive therapy, and one thing I think that's unique to mention about this protocol versus the other ones we discussed is that this is a group protocol. There is no individual mindfulness-based cognitive therapy. There is, but it might not look like this per se. And this, I'm going based on the actual kind of developed maintenance therapy for remitted patients with depression. So what is this exactly? Well, it's essentially mindfulness-based stress reduction, which I'm sure many of you are familiar with, combined with a cognitive therapy. And as Meghan mentioned, it's developed as a maintenance therapy for patients with remitted depression to interrupt these automatic processes. And everybody here has talked a little bit about this, and I think that's also a really key component of these therapies, is that we're looking at kind of what are the things that we're doing just without awareness, right? So I don't know if I'm the only one who's had this experience, but it's happened to me before that on a Saturday I've gotten in my car and I've had lots of things milling about in my mind and thinking about, oh, I've got to do this and that and all this stuff, and all of a sudden I pull into the parking lot at work and I think, what am I doing here? It's Saturday. And that's kind of an example of automatic pilot, right? And so what do we want to do? We want to really interrupt this process. How do we do that? Well, we need to learn how to accept and observe without judgment. So when I get into that parking lot, I could start getting really frustrated with myself, or I could say, oh, silly me, and go on about my day. And so really we're teaching our patients how to do this. So I want to just mention briefly that while the therapy was developed for remitted patients, there's more data coming out now that shows that it's also effective for generalized anxiety disorder, panic disorder, somatic symptoms, social anxiety, active depression, bipolar disorder, insomnia, chronic pain, and on and on. And actually the protocol that I do as part of our CBT group, I've modified it a little bit to be able to treat patients with active depression and anxiety as well. And how I've done that is not really to modify any of the kind of components of mindfulness, but more to add more cognitive therapy tools. So essentially, I'm going to start just by describing what the therapy looks like. So it is essentially 2-hour group sessions for 8 weeks. There's an optional all-day retreat and an optional reunion session. When I run the protocol, we do the reunion session, but we don't do the all-day retreat. Billing purposes. We run them typically about 8 to 15 people per group. And I think one of the things that's really important to mention that Meghan alluded to is that this is a protocol that requires active participation on the part of the provider. And what that means is that the provider has to have their own mindfulness practice as well. It's not enough to read the manual and go in there. You have to be actively have your own meditation practice. And I think it's worth mentioning that a lot of the mindfulness exercises in this protocol are meditation-based, which is a little bit different than ACT, which focuses more on the use of more general acceptance. We're talking here about kind of getting there less through metaphor and through our own experiences in life, but more about kind of really honing in on focusing on the breath and meditation. In addition, I think one thing that's really important to mention about this protocol is that there's a lot of homework. Patients are asked to practice between 45 to 60 minutes a day, 6 days a week. The 7th day, they get in a group. So essentially, this is meditating every single day. And the homework isn't only meditation. I'll talk a little bit more about the other kind of active components that are included as well. But it's worth mentioning that the majority of the homework is focusing on building openness, awareness, and activity. So I'm going to start by talking about awareness, because this is how the MBCT protocol starts. Essentially, we educate our patients on what automatic pilot is, right? We talk about that, and we talk about how our attention is flexible, and can we bring our attention to the present moment. So really, we focus on kind of having our patients share examples, as I shared, and then having them tune into the present moment. So the very first meditation that's done is a body scan. And a lot of times it's hard for patients to necessarily stay in the present with their thoughts, because we're not used to that. Our thoughts kind of run off sometimes. And so how can we focus on our bodies? How can we focus on physical sensations to bring ourselves to the present moment? Another exercise that's used to kind of promote awareness very early on in the mindfulness-based cognitive therapy protocol is the raisin exercise. And this is taken from MBSR. I don't know how many people are aware of this exercise, but essentially it can be used to promote mindful eating or just awareness. So everybody gets a raisin. Lots of people say, I hate raisins, and we encourage them to do it despite hating raisins. They take the raisin in their palm, and they essentially, to kind of do this quickly, examine it with their 5 senses. What does it look like, taste like, smell like, sound like, and feel like? And then they're encouraged to take this exercise into their lives, not necessarily only around food, but when you are sitting in your car, what do you hear? What do you smell? What do you feel? All of these kind of different components, and how can you use this more broadly? I should also mention that, I think that the awareness exercises also promote openness, right? There's no kind of distinct, okay, this is an awareness exercise that has nothing to do with openness. I think there's a lot of overlap here, but the beginning of the protocol really does focus on building awareness. From there, we go to openness. So how do we start to live with kind of a more accepting and open stance and view? And I think it's important to mention that we're not talking about radical acceptance. We're not talking about, loving everything. It's not about going from, I can't stand this, to this is the best. That's not what we're talking about. We're talking about just this non-judgmental present moment awareness. And so how do we get there? And this is where a lot of the kind of mindfulness and meditation practices take place. And so the backbone of MBCT is this 3-minute breathing space. And it's worth mentioning the 3-minute breathing space. You can kind of visualize this if you were to take the exercise and think about it as an hourglass. So what we do is the first minute, you're really asking your patients to just develop an open awareness of experience. So what is happening in your body? What is happening in your thoughts? What is happening with your emotions right now in this moment? The second minute, we ask them to focus on their breath, right? So gather your intention to feeling the breath. And from there, the last minute says, okay, now that you've kind of gone from this broad awareness to this focused awareness, now can we have this kind of wide open awareness? So can we start to consciously expand our awareness to the whole body and breath? Right? And so now it's not just focusing on everything, it's not just focusing on the breath, but the body and the breath in this more integrated way. And really that's a practice that patients are doing mostly throughout. After kind of the 3rd week, they're doing that every day, multiple times a day. They've also taken that 3-minute breathing space and developed a 3-minute coping space, which is very much the same meditation, but in the audio file, it actually cues people to think about that difficult thought, that difficult experience, right? Don't kind of shy away from the negativity, but can you hold the negativity? Can you be with the negativity in a non-judgmental way? And that can actually help us to cope. We also do a lot of focused attention meditations, which are mindfulness of the breath. This includes kind of different durations of mindfulness of the breath. So in my protocol, I've modified it slightly because originally they start with longer meditations in the kind of 10-minute range. And I found that when we're working with more actively anxious and depressed patients, that's a hard place to start. So we actually start with 3 minutes, and then we build up on that when we're looking at mindfulness of the breath. And then we also include mindful movement, stretching, breathing, walking. No formal yoga, but just even in the room, we do kind of a walking meditation, and then I encourage patients to take that out with them and practice that for homework as well. Moving to kind of the active component, this varies slightly in that there isn't a lot of focus on in the way there is in behavioral activation on kind of building this meaningful activity in your life. Rather, it's about noticing the meaningful activity that's already happening with this new awareness. And how do we do that? We ask our patients to, for a week, record one pleasant thing a day. And it's amazing to see patients coming back in and saying, oh God, I'm so depressed. I didn't think anything good happened in my life. And wow, look, I was able to notice one thing a day. And it could be simple. It could be I walked outside and I heard a bird chirping, right? But those are the things that if we're not aware, we're not noticing. The other thing is we really encourage daily mindfulness. So hopefully all of us brush our teeth. Can we do that mindfully, right? Can you take a shower mindfully? Great place to check in with your 5 senses, right? Can you take out the trash mindfully? The things that you're already doing, can you start to approach them with this open, present moment awareness? And then the last piece is helping our patients in the way that Abby had mentioned, kind of scheduling and building in the routine of their new mindfulness practice. And so how do we maintain that and put it on the calendar and put it on the calendar again? And so that's essentially kind of in a nutshell what the therapy looks like.
All right, so to sort of wrap this up and give you the sort of the second piece of the patient, Teresa, who's actually here, and what she went through. So this is her treatment response and outcomes. I'll break this down, but I want you to be aware that Teresa went through the ACT group with me, the ACT group for mental illness, and then also did individual treatment with me. These responses, or this sort of graph here is, I know it might be a little bit hard to see, but I can show you. These are really good results. But so this is just her score. So this first light blue is an anxiety measure, anxiety sensitivity measure. So at prior to the ACT group, she was quite high. This is very much above the clinical cutoff for anxiety. And then at the end of ACT, the ACT group, she was at a 31, and then this was sustained at about 2 months afterward. This dark blue line is the AAQ, which is our measure of experiential avoidance or psychological flexibility. So down is good. That means less experiential avoidance. And this is sustained like over a year follow-up, which I shared that with Teresa recently about how long this has been sustained. And this is the key outcome that we're looking for. And then this last one here is just distress tolerance, and up is good. So she was improving on her ability to tolerate distress, tolerate negative affect, tolerate physical distress, all of those kind of things. So in terms of treatment outcome, I'll give you some sort of functional stuff and meaningful action and values. She's driving independently, so that was something that I think that was a huge step for you. She was not driving when she first started treatment. She engaged and completed her Hep C evaluation for antiviral therapy. That was also, I think, a big treatment outcome for us. She started a sleep study to sort of work on potential sleep disorder issues. She began a part-time childcare service. That's something that she very much loves to do. She returned to church. She's had a steady, sustained weight loss. For a while, she was doing a walking social group, and now she's exercising at a gym. And she's reconnected with many family members that she's had difficult relationships with that have, a history of severe mental illness that have been very, very tumultuous. And she's chosen to reconnect in, I think, a healthy, balanced way with these family members. So Teresa, if you want to come up and share your experience, we'd appreciate it. I'm so happy and appreciative that you're here.
Well, to tell the truth, the doctors already done told my story. So they've already said everything that really happened, and I'm glad it happened the way they said it happened. So because they explained so much, I don't have much to say now. So what I'll start off by saying good morning, and I'm happy to be here. When I was at my lowest point, like Dr. Oser said, when I was at my lowest point, I found myself coming back to Brigham. Women had been 35 years. I hadn't been to this hospital since I had my appendix had erupted. So at my lowest point, I found myself back with a PCP, and my primary care doctor, he told me about Dr. Oser, and that he made me an appointment to come and see her. So as I was learning things, I learned new tools that I can really use to help me to become more active. And while I was learning these tools to cope with, I learned about my values came back to me, because you got to remember, after being laid off, I laid in bed for a year, just trying to figure out what to do. And as I stayed there and I tried to figure it out, it wasn't coming, but my mind was still working, because eventually it led me back 35 years to Brigham Women's Hospital. And as I began to learn and to meet with Dr. Oser and to go to the ACT group, I became mindful of things. I became mindful of all my thoughts again. I began to change my behavior because of the learning that I was getting from the group and Dr. Oser. I learned to stay in the present. Like the mind is gone. The mind is always traveling. But I learned to stay in the presence. And all that negative behavior that I had for those years in bed, that negative behavior, just like I learned that negative behavior, I was able to learn positive behavior. And that positive behavior made me active again. And it helped me to able to differentiate between what's good and what's bad and what's evil and what's good for me and where I stand. And I became aware of all this stuff that was happening in my head. And as I think about it now, I say to myself, a mind truly is a terrible thing to waste. It's a terrible thing to waste, because you can tell your mind, if you tell your mind something long enough and loud enough, you begin to believe it. And if you train the other way so that you can have some positive thoughts, then your mind will do positive thinking. As Doctor said, I began to be mindful of everything I was doing. I lost the 45 pounds. I'm up now. I go to exercising class 2 to 3 times a week. And I learned how to breathe. I learned how to breathe, how to take some deep breaths. And as I learned how to take the breath and reading all the material that I was given, I became mindful of my breath, just my breath alone and me. And we have to tell ourselves, sometimes I send my mind to the beach. Because I need a break. And another thing I learned, I like to say, I'll think about that later. I'll think about that later. But later don't have to come. It don't have to come. I love that one. I love it. And a year and a half ago, I lost my sister. I love my sister. She was 53. And she would be so proud of me today, because if I could have written her death certificate, it would have said PTSD, anxiety, and depression. But if I could say anything here that would mean something, a year and a half ago, you couldn't have told me nobody cared. But looking around this audience today, I would like to say thank you for coming and thank you for listening.
Thank you, Teresa. So for the sake of time, because we have 10 minutes left, I'm not going to babble anymore. I think you've said everything that needs to be said. I want to leave it there. And I just want to open up, I think, for Q&A and the panel discussion. I think that'd be the best use of our last 10 minutes.
Hi. That was wonderful, altogether beautiful story, and your story is just really heartfelt. Thanks for sharing. Just a methods question for you all, sort of a question about, you all presented different forms of therapy, behavioral activation, MBCT, or CBT. How often do you feel that you're using one protocol over another versus just taking from all of those whatever works in the situation for the patient?
Yeah, I'll take a stab at that first just because I did individual treatment with Teresa and then she was also in the ACT group. In individual treatment, when I was actually looking back at the notes from a year and a half ago, I started off with behavioral activation because she was so depressed and so inactive. It was that was the sort of stuck point at that time. And then moved in more to some of the ACT-based components. So I think it is very flexible because it's sort of in this broad umbrella of contextual CBT. So I think especially in individual therapy, we have the freedom to be very flexible if you've sort of been trained in different protocols. And then I think we use our kind of clinical judgment about what's the highest priority first. But I think that, and it's not a linear path, of course. I also did some self-compassion work at the end with Teresa at the very end of our treatment recently. But I think in the group, and I think the other presenters can also speak to this, the group, we tend to focus a little more on the protocol. So I think it's easier to follow. It makes it a little more coherent. And
Thank you.
Thank you. This has been very useful and informative. You mentioned the benefits for certainly depression and anxiety. I was wondering if there's been work done with groups for substance abuse and addiction, especially in the young adult population.
I personally don't know too much about this. I know that there are mindfulness-based protocols for substance abuse. Working only with adults, I'm less aware of kind of how that would translate to adolescents and children. I'm sure there's stuff out there. If you come up after, I can give you the name of somebody. I can check a name of somebody who does specifically kind of this. I don't know necessarily in terms of what the protocol looks like, but there's a mindfulness-based protocol for substance abuse.
yeah, I can say one quick thing about that. Mindfulness-based stress relapse prevention is the equivalent, I would say, of these kind of approaches, but very heavily focused on mindfulness. And they do things like urge surfing when you have cravings, and that has, I think, pretty strong empirical support at this point and for substance use for adults.
There have also been, I think, ACT studies with substance abuse and also smoking cessation, and ACT has also been applied, has been used with adolescents as well.
So again, fantastic presentation, and thank you again for being so generous of sharing yourself with all of us. I'm just curious, how are decisions made in terms of how people are triaged into the different protocols, or is it just what's available at the time? Or is there, and the other question is if you can talk a little bit about how patients are access and pay for some of these services.
Okay. I think in terms of sort of the triage, we initially, I'd say most of our referrals come from, I'd say initially into psychiatry through primary care, specialty clinics, and sometimes also folks come specifically for cognitive behavioral therapy evaluations. And I'd say usually people start with the evaluation. They may initially start individual therapy, and like you mentioned in your question, groups do run on different sort of time frames. Sometimes they're running, sometimes they're not. So usually I'd say we make the best decision. Sometimes we consult as sort of what would be the best fit for that individual at the time, or they might be on a wait list for when the group might start up next. But I'd say in general, there's usually like a little bit of a funnel. Like initially, if an individual, maybe they've had a lot of individual treatment and they're looking for something different, and so maybe all we would offer initially is group therapy. I would say a lot of individuals that do come through our clinic, if they are engaged in the group therapy, they have also probably engaged in individual therapy as well, before or after. In terms of coverage, I could pretty much say group therapy is usually always covered. In many ways also, I'd say insurance companies like that better due to sort of the cost, but never had any problem with coverage. And there's no sort of prerequisite of like individual therapy, like that it didn't work or there was any sort of failure to be able to engage in group therapy or sustain that or do both at the same time. So some individuals are in group as well as individual at the same time.
Thank you all for such a great presentation. There was one event, though, that was not explained that was a near miracle to me, which is, I was going to ask Teresa, you were in bed for 1 year. What made you get out of bed?
Like I said, the mind is really something else, but it's still working. You're telling yourself all this stuff, I got to be here, it's going to be all right. Avoidance was my only coping mechanism. But your mind is still working, and I knew I had to get up because I like life. I love life. I want to live, and I'm finding myself a year just there. So finally my mind told me, you got to get some help. Like, it has been 35 years. I'd never stepped into this hospital the day I left. I never came back, but I just knew I needed something. I needed help. I needed someone to talk to, and I wanted to live. I really wanted to live.
You think it took, like, if Meghan Oser showed up a year before, would she have been able to reach you at that point?
Yes, because I like life, and I don't know what, but see, life puts you there.
Yeah.
The mental, physical, social, emotional baggage that we carry, and that we continuously tell ourselves we have to carry, and people please, all of that, But you have to, your mind will tell you it's time to get up. I need a change. I just wish everybody could have this type of therapy. I really, really wish that it was some way someone could just be at a table and just see people as they come and say, I got, there's a group therapy meeting on Tuesday. Would you like to come?
Yeah, and I just want to say one thing. I mean, she didn't come in seeking psychological treatment. She went to her PCP first for a medical evaluation, and then they referred. So.
I just want to, it's a wonderful presentation, and one of the things that was mentioned at the beginning was the way in which providers of these treatments have a practice. So they have been trained and are practicing either 3-minute meditation or some kind of. And I'm wondering if, Teresa, if you felt when you met Dr. Oser or worked with some of the other people, that in a sense you were talking to somebody who had walked down the same path or had some sense of, you were talking to somebody who knew something about your journey.
How did I connect, or did I feel comfortable? Or yes, I felt very comfortable. I wasn't intimidated because I knew I needed help. I couldn't stay in that bed. I was gaining weight. I connect really well. And like I said, I wish my sister had had that chance, or would she have accepted it? A lot of us, we suffer in silence, and a lot of people don't want the help. But I was ready. I was ready for the help.
So thank you so much, again, to all of our presenters and our patient. Thank you very, very much. So I want to first thank you all for coming. Please, if any of you have not signed in on the way in, please sign in on the way out. I want to welcome you to our coffee hour, which is if you just go out the door and turn right, There's some coffee and refreshments for you all, and we hope you get a chance to stay and meet each other. And I want to also let you know about two of our upcoming events. One is a presentation this Thursday, February 4th, from 4 to 5 in the Shapiro Breakout Room. This is Dr. Terry Ellis, who's going to talk about application of mobile health technology to facilitate long-term engagement in exercise in persons with Parkinson's disease. This is our research seminar on Thursday. And then our next presentation a month from now, or the next Grand Rounds, is going to be presented by the Berklee College of Music. Should be very interesting also. Integrative Health Through Music Therapy, Research Practice and Live Demonstration. So Dr. Suzanne Hanser and Daniel Kokabia. So thank you all for coming, and see you next time.